So an implantable cardioverter defibrillator is a specialist device that we insert under the skin in patients who are at risk of sudden death due to a fast ventricular rhythm. It's recommended usually if someone's already had a cardiac arrest or if we think that they're at high risk of sudden cardiac death due to a ventricular arrhythmia. So the majority of defibrillators are implanted under local anaesthetic and with sedation, but sometimes under general anaesthetic, depending on the device and the patient. We make a small cut in the skin under the left collarbone. Sometimes we put them in the left axilla region, sort of below the armpit, but the way that the devices work is very similar. There is a box, the generator, that is under the skin by the collarbone or axilla, and it is attached to a lead which usually goes into a vein that goes under the collarbone and leads to the heart. The device can then detect abnormal fast heart rhythms, and if it thinks appropriate, it can either try and pace your heart out of that fast heart rhythm or give you a big shock to the heart to get you back into a normal rhythm, ideally before you collapse or have significant symptoms. As with all invasive procedures, there are small risks involved, which are outweighed by the benefits in the vast majority of patients. The common risks are infection. To reduce that risk, we give antibiotics beforehand, and in some patients, we can put the devices in antibiotic envelopes to reduce the risk of infection. There's a risk of bruising and bleeding. This isn't usually serious. There's a small risk of damage to the lung requiring a drain to be put in, but there are various techniques that we can use when getting access to veins to reduce that risk also. There's a small risk of fluid collecting around the heart from where a lead can perforate, but again, there are various techniques to reduce that risk to virtually zero. Finally, there are risks that the device can shock you inappropriately. So although the device is there to shock you when you have an appropriate abnormal heart rhythm, in around 5% of patients can get shocks when they're not required. We can almost always program around those sorts of problems should they arise, however. So immediately after implantation, we usually put a dressing on the wound, which we advise patients to keep on for 5 days so that there is good healing under a sterile environment. Longer term, we say for the first month after a device implantation, they shouldn't drive. If they then have a shock from the device, we normally recommend that they don't drive for 6 months, but that is up to the DVLA, who will write to us for further information. You do need to inform airports when you go through security that you have a device, and they will usually tell you to walk around the metal detectors.